Right, well, good morning everyone and welcome to the second of our keynote presentations of the day. Today marks the midpoint of the Modern Ward Round Collaborative, so we're 3 months into the programme now, and today is our shared learning event. We have this morning 3 keynote presentations. And we're about to start our second one, and then this afternoon we've got a poster presentation for the work so far, and then a wrap-up session afterwards. I'm not going to do too much talking because if the next talk is as good as the first talk, which I'm very confident it will be, there'll be lots of discussion and debate to be had. So I'm going to just quickly introduce our speakers and then hand over to them. We'll be facilitating some question and answers at the end of the presentation. So please do put your questions and comments in the chat box, which we will curate and bring people in at the end. Or if you wanted to speak afterwards, just raise your hand and we can bring you in at that stage. So just to introduce our speakers this morning, I'm delighted that we've got Sankara, Raman and Elaine Frearson from the George Eliot Hospital who are presenting this morning. So Sankara and Elaine are doing a lot of work on shared decision making, which has been a highlight really of the collaborative so far and the patient engagement side of the QI work that we've been doing. Their work was part of the original Modern Ward Rounds case studies, and we felt that rather than just putting the presentation as a quick presentation in one of our learning events, actually this is so important we'd make this a keynote presentation. So Sankara and Elaine, I'm delighted that you've been able to join us today. I should also caveat this, that I'm a gastroenterologist, Sankara's a gastroenterologist, Elaine manages the gastroenterology ward, and it's not a gastroenterology mafia, but it's lovely to see fellow gastroenterologists and GI specialists working together with QI. So Sankara and Elaine, thank you very much for joining us this morning. Over to you.
Right. Thank you very much for your kind words, Andrew. And yes, it may not be a mafia, but we're all still stick together. That's very much a brotherhood, isn't it? To be on that's the lighter note, but thank you very much again to all of you for this opportunity. I think it is great to be able to showcase some of the great work that our team's been doing. Full disclosure, I have to say, I think a lot of this work has been done by our ward manager, Elaine, and I'm just effectively shouting her kind of successes from the rooftop here, and I'm riding on the coattails of her. I'm riding on the coattails of her success, really. Right? So basically, this is something which was set up 2 or 3 years ago at the George Eliot Hospital. This can we have the next slide, please? Thank you. That's just to kind of tell you a little bit of who we are. As Andrew said, I'm a consultant gastroenterologist and clinical lead for gastroenterology in my own trust. And for my sins, I'm also the director of medical education for the trust as well, which is something I've been doing for the last few years. Next slide, please. So a little bit of background to us. Basically, George Eliot Hospital is a hospital in Nuneaton in Warwickshire. The trust, as it's obvious, was named after the Victorian author, George Eliot, who was actually born in Nuneaton. She was born as Mary Ann Evans, but decided to write under a male pseudonym as this would be more acceptable. And I have to say, she is an author who is probably way ahead of her time. And she's one of the authors who I would certainly recommend to all of you. Some of the books are really worth reading. Books such as Middlemarch, I think, are considered among the greatest works in English literature. And I think they're well worth a read. And some of her ideas about healthcare in the 19th century are something I think our Department of Health would probably do well to heed in modern times as well. So we are an acute district general hospital in the West Midlands. Our catchment population is not hugely different from a lot of DGHs up and down the country, about 300 to 320,000. We have all acute services as you would expect in a DGH, which includes emergency services, A&E, acute medicine and acute surgery, all the specialties, obs and gynae as well, and all the kind of medical and surgical subspecialties as well. Next slide, please. So Gastroenterology covers 2 wards in the hospital. Mary Garth is one of the 2 gastroenterology wards and that's the ward that Elaine is the ward manager for. The other gastro ward is Adam Bede. And as you can probably see, there's a George Eliot flavor coming through. All of the wards in the trust are actually named after characters in George Eliot's novels. So each of these wards is made up of 18 beds, mixed sexes. There's a mix of gastroenterology and general medicine, as would be the case in any district general hospital. Can I have the next slide, please? So why did we choose to do this? I think the ideas that we wanted are not hugely different from ideas that a lot of people have had across the country. It's about optimizing communication between the doctors, between nursing staff, the auxiliary staff and patients and their relatives, improve the team working experience for all the staff. Obviously, as all of us want to do, improve the patient journey and the patient experience right through. And most importantly, obviously, reduce any potential complaints that we may have. I mean, these, as I said, aren't any different from anything that anybody else in the country or any ward in the country would want to do. But it is just about how we actually go about doing this. Can I have the next slide, please? So that's where I think Elaine actually came up with this, that there might be a different way of doing this, and came up with the idea of the Shared Decision-Making Council. This led to a lot of improvements. One of the important key ones was the bedside communication tool, which we devised as a result of this. And I think it really helped, this decision-making council really helped to empower staff and really enrich the patient journey. I think, and that's, at the end of the day, that's what we all want, isn't it? We want our staff to feel invested and empowered. We want the patient journey to be enriched. And I think this actually fitted the bill and actually did both of the things that I think Elaine was hoping for. Can I have the next slide, please? There were barriers, as you can imagine, with any new initiative, with any new kind of idea and an innovation. There is going to be barriers. And the first thing would be about getting engagement with the staff members and how to convince them after the initial meeting. Again, as with all of these things, the take-up always tends to improve with word of mouth. And then encouraging the staff to then complete and update the communication tool was the next challenge. And I think, in a way, I think Elaine kind of utilized the Cotter's 8-step model of enriching and kind of enhancing change, but I think in a kind of informal kind of way, right? So I think without further ado, let me hand you over to Elaine, and I think she'll go over in much more detail than I probably can about how she went about this, and then we'll talk a little bit about what happened after this and post-COVID as well. Over to you, Elaine.
Thank you very much, Dr. Raman. So I am Elaine, I'm the ward manager for Mary Garth Ward, and we do have our own Twitter page, so if you want to follow us on Twitter, please do so. Get tweeting about us. So we are a group of staff varied from band 2s to band 5s, band 6s, band 7s, that all really want to make changes. And what I felt as a manager was people would come to me with their ideas of what they want to change and expect me to change it all, but I've got a lot of work to do. So it was actually good to get them involved to make the decisions themselves, actually put into action the changes that they wanted to do. So voices were being heard and people were making change. So the frontline staff, as I've said, and we welcome all voices and ideas, and that's just a little picture of our meetings pre-COVID, may I say. Next slide, please. Okay, so we put the council together because we wanted to empower the staff. We wanted the changes to be made from the floor up, and we're the people ourselves that are changing the future of the NHS. We've got empowerment, we can make changes. We don't need to go higher and above to make the small changes in our workplace. And it's kind of thinking a bit differently, how we can make ourselves heard and how we can improve the small details for our patients, for our staff, and how that impacts us as a team. Next slide, please. So one of our projects was to improve the communication between our patients and our relatives and the MDT within our ward. We decided to look at communication because our complaints had increased over the last few years. There was common themes around communication between patients and relatives. Patients were telling their loved ones they hadn't seen a doctor, they hadn't been informed of what the plans were for their care whilst they were inpatients, or basically how long they were actually staying in hospital for. And some of this was because patients couldn't remember, patients were forgetful, or the doctors would see them, and because the doctors are always the busy ones, never the nurses, they didn't want to ask questions again. So they actually didn't really understand what was happening. So our ward rounds and board rounds happen Monday to Friday, daily, with a consultant or registrar lead. And what we found is when we had visitors in the hospital, relatives would come onto the ward and want to see the doctors, want an update with what was going on with their loved ones, because the patients were saying they hadn't seen anybody, they didn't know what was going on. And this was taking up a lot of valuable time for doctors to actually sit in with patients and their loved ones to go through what was going on with their care. And we felt that other tasks were being missed, quite important clinical tasks for patients and their care. So we tried to formulate a way of how we can improve communication. Next slide, please. So just a bit of background about the council. So we formed in July 2018, and initially we got staff to volunteer to who wanted to join the council, which was very difficult at first because it was something new. People weren't really aware of what they were going into, but they knew they wanted to make change and they had a voice. So what we do is we would meet once a month for 6 hours at a time, and just get together and bash all these ideas out of how we can improve change. We have a monthly leadership council with the chief nurse, and we now actually have an appointed leader for the councils across the trust, so everybody can get together and share their ideas across the trust and also to the trust board as well. We discuss any obstacles we faced, whether it be getting the time to meet with the council, or if we had a problem trying to get estates to support us with moving forward with any projects. Next slide, please. So this is an example of our tool that we came up with. So this is one of many versions that we came up with, because obviously the first version never goes to plan. So we devised a tool that was left by each patient's bedside folder, where with their consent we could document what the patient was coming into hospital for, what the expected plan of care was, and how we can plan for patients to leave hospital, because we all know as soon as the patient comes into hospital, we want them to get out of hospital safely and with the care correctly received. So we left it by the bedside with the patient's consent, and it assured patients and relatives that patients were actually being seen by the correct people and care was being actively provided. And what we would do on a ward round, we would go round, and on the Monday we'd put that the doctor had seen the patient and what the plan of care was, not in great detail but a brief summary. So people were able to see, actually, you saw Dr. So-and-so and you were going for a CT scan for this reason, or you are being treated for this cause. And that gave a lot of reassurance, and actually really has reduced the amount of time doctors are spending with relatives explaining what they said on the ward round. And in turn, we have actually reduced our complaints massively. I don't think we've had a complaint since last summer around communication. And it's allowed us all time to focus on the clinical care. And that gets updated daily, and it's left by the patient's bedside. So one of the versions we did previously was whether we gained consent. And obviously not all patients want everybody to know what is going on with them, because relatives always like to pick up a folder and read through the notes. So we did have to gain consent. Next slide, please. So our challenges were committing ourselves to the statement. We are committed to listening and influencing positive change to benefit staff and patient wellbeing. communicating our ideas to the ward staff and making sure they were involved in understanding the projects we have worked on. So we would put a project together, and we found that we'd put it in and we'd expect the rest of our ward staff and clinical staff to be forthcoming with the idea, but because they weren't involved in the actual project of putting it together, we then realised we had to actually get their feedback and actually see how it worked from pen to paper and actually into practice, because what you think might work doesn't always go to plan. So what we have done is rotated staff members throughout the leadership council, so other people are getting their voices heard as well, and other people have actually got other ideas. We're learning that our projects can affect others indirectly, and to adopt a PDSA approach. So one of our projects as well was, we thought we would do a nice thing and decorate the staff room. However, our staff room was a shared staff room, and another ward was not happy that they were not involved in the communication of what was happening. Even though we did it as a benefit, it actually did cause a bit of tension in the process because they wanted to be included. So we took a lot of learning on how we approach and tackle different projects that we've done. Challenges, especially now, is getting the time. So we've allocated 6 hours a month to all meet up. So we're away from the unit and we put together these projects, but obviously COVID came along. So we've had to think differently on how we can continue the shared decision making council. And Microsoft Teams, as we're all on now, has been a wonderful approach, but it is more difficult to bounce your ideas off. But it's actually gave us a bit more structure because we've delegated tasks to different staff members that are in the team. And then building up a network with other people in the trust, so making sure they understand what we're trying to do. So, for example, getting estates to get on board, usually they want things signed off by the ward manager. And if the ward manager is not involved in pursuing a project such as refurbishing the staff room, then they want a cost code to go to, and so on and so forth. Next slide, please. So what are our successes? So seeing our projects rolled out and being utilised. So the staff room is actually a success. It's a nice place for people to go for their break, to actually have time out away from the unit in a vibrant space, with different notices about positive things that are going on in the trust, training, and actually silly little things like having a microwave and a kettle, just to support their staff lunch. Skin surveillance. So another project that we had was an increase in pressure sores on the ward. So we were understanding, why are our patients getting more pressure damage? How can we change how we check patients' skin, how we can check their patients' wound? So we formulated a new tool on skin assessment as well. We've also completed a wellbeing box. Little things like hair bubbles, deodorant, a spare pack of tights, in case anything happens on staff while they're on shift. Just to kind of give them a bit of a freshen up and everything like that. And so many projects we've done. So thank you box as well, something so small. We don't say thank you to each other enough, especially during these COVID times, like the appreciation we have for one another. So little cards we put in, just to say thank you to other people, that you're doing a good job. Everything you are doing, we really appreciate it. And again, the communication tool with the MDT that we leave by the patient's bedside. And there's some others there that we've got, and I've got a few pictures on the next slide, I believe, of what we've done with the falls and the cupboard gate. If you can go on to the next slide, please. So, as you can see on the right hand side, we had a spare cupboard, which is very unusual in a hospital, and it was just literally a junk cupboard, and everything just got chucked in, and actually we were not using that space to its best capacity. So we actually got estates in on board, took the shelves down, gave it a look of paint, ordered some lockers for the staff so they could put their belongings away in a safe place, taking storage away from the ward so it was clutter free, which in turn led to the corridors being safe, clear, patients could walk around. We want to prevent falls because inevitably people do fall over. Was the signage to prompt patients to say, have you got everything you need before you can mobilise? So we put posters along the walls. So just it's the smallest things that make the biggest difference to staff. They feel like they're empowered. They feel like they're actually making changes, and it's actually a good place to work because patient safety is paramount. But in turn, because the staff are happy, my vacancies are low. I started this job 5 years ago and I had 8 full-time nurse vacancies, and I've got to a place where we've got none, which is quite unheard of currently in the NHS. So it's really good for staff morale. Next slide, please. So what have we learned? That we can actually make a difference on the ward, on the unit floor. We don't need to go higher up to the directors of nursing, to the operational leads. We can actually make the changes now and get our voices heard. And that in turn has actually got other areas making up their own councils and like making changes across the trust. It's brilliant, really. We're quite tangible and we're valuing the improvements that we're making, and we're learning day by day what changes we need to do, and not all these changes work straight away, so it's learning. We're networking, so like today we're sharing what we've learned, we're sharing our ideas, so people in other trusts, other areas can get their own councils build up and learn how to improve their practice as well. Networking amongst our own hospitals, so estates, directors of nursing. So band 2s are having meetings with director of nursing that they would never have dreamed about doing before. They're speaking to people on another level. We've had meetings with the previous health Secretary of State of Health. He's come to look at our project, see how we're developing as well. Presentation skills, as band 2s, they tend to not do a presentation to the world, like the trust and everything. So they're developing their confidence and presenting to people that they would never have spoken to before. We're developing our own skills. We're learning about staff members on a different level. People have got so many ideas and skills that when you come to work, you just work on the ward, you look after the patient, and that's all you really get to know. So we're really developing ourselves, and we're learning to compromise because not everything is doable. Small steps, small baby steps make a bigger difference at the moment for us. Next slide, please. Okay, so back to Dr. Raman. Oh, you're on mute, Dr. Raman.
Thank you for that, Elaine. So everything was going swimmingly, but life, as we quite often know, has other plans, and I think it had other plans for the planet in early 2020. I think we had a huge, obviously, change in what we did, what we managed to do, and how we actually do things going forward. And as I mentioned, there's a complete fundamental transformation in the delivery of healthcare and in the provision of healthcare thanks to the pandemic. So it changed completely the way we communicate with each other, with our patients, with our colleagues. Huge barriers to interaction because obviously the hospitals were shut down for visiting for long months at a time. The meeting formats completely changed. We had, most meetings now being on Zoom or on Teams. The words "you're on mute" or "legacy hand" I think were unknown to any of us, I think till about 18 months ago. And I think that's part of the kind of change that we've had to kind of see. And the patient journey obviously changed as a result of this as well. That's just a picture of myself in full PPE going into endoscopy, which Andrew will appreciate, with the full FP3 mask as well. And this is just part of how we've had to adapt. This would have been unthinkable for any of us in endoscopy just 18 months ago. Next slide, please. So, as I mentioned, we had to make meetings virtual. The communication with patients, relatives, and next of kin became so difficult because of this change, having to be virtual. I mean, obviously, all of us have faced this kind of difficulty with patients or relatives having to say goodbye to loved ones or things, or via FaceTime or on Zoom. This is completely unheard of or unthinkable, and the kind of heartache and the kind of long-term effects that has on morale and psyche cannot be overstated. So as a result of all of this, the pastoral support that we needed to put in for our staff members and the well-being became a huge priority for myself as head of education for our juniors, but also with our own ward staff and Elaine for her own staff on the ward. We unfortunately lost a staff member due to COVID on our ward. We also lost a very valued junior doctor, which is probably an indirect effect of COVID due to the pandemic itself. And all of that takes its toll on all of us mentally, physically as well. And I think we had to put in so many kind of adaptations and support for each other for well-being. So maintaining that ward structure and integrity became really a priority over that period of time. And the decision-making council in a way had to adapt to kind of look at the new reality, and I suspect this new reality will be with us for the next 2 to 3 years. I can't see that changing substantially in that time. Next slide, please. So a lot of these changes, I think I'll bring Elaine in again. She can talk about how we actually did this with regard to the patients and the communication with them.
Yeah, so thank you. So obviously we've got no visitors in the hospital at the moment, only on compassionate grounds for people that have got end-of-life care and so forth. So how did we maintain communication with relatives? So what we have done is we've actually set up a password system for patients next of kin. So we give information to one delegated member of their family, so they are up to date with what is going on. And with the communication tool, instead of documenting what has happened on the ward round, we document who we've spoken to and information we've given. So we're aware of which people have had their families spoken to and so forth. So we've just basically adapted the tool slightly, and notes aren't left by the patient's bedside. So we can go to, actually, we haven't spoken to the lady in bed 4, their family for a week. They keep calling up what's going on. And as you know, getting through to a ward via a phone call can be very difficult at times. We're also utilising, we've got iPads on the ward as well, so we can do FaceTime and Skype meetings with family and loved ones. And it's quite reassuring for the relatives to know that their loved ones are okay, they are safe in hospital. What is going on, so we can actually do conversations via the FaceTime, which actually has helped, and it's been a real beneficial tool we've got within the trust. And it's also reassuring for relatives, because even though they can't physically be next to them, they can see them. And it's quite interesting how a 100-year-old can actually use FaceTime quite well. Next slide, please. Okay, so what are we proud of as our council? We're proud that we've made changes and it's been valuable. We're proud that we've made ideas that can be translated from paper to a success, and we can share our ideas. It's given staff the momentum and the dedication to continue to strive to do good, make themselves proud and push the council and push change. We were the first council at George Eliot, and now I think we've got about 10 to 11 councils in the trust. And we've presented our models to the Workforce Development Committee, to various workshops within trying to build up other wards and units, getting a council together. And we've actually had the Secretary of State of Health come and visit us on our ward and ask questions about how we've made changes and how we've made it successful. Next slide, please. So what is next? So we are committed to keep going and keep pushing changes. If we change nothing, nothing will change itself. We want to be the voices that are heard to make the changes rather than be dictated to what changes are being made from the trust and the management side of the organisation. So we want to improve discharge planning, which I'm sure kind of communication around how we devise a discharge letter. The big thing at the moment is patients feel their discharge letters are too medical for them to understand. It's based for a GP rather than for a patient. So how can we improve that? How do they know when to take their tablets? Because taking a medication OD times like that isn't clear for a patient. We know as medical professionals, but for a patient. So that's a lot of things that we want to try and improve. And we want to keep the councils growing, we want to keep them running in the trust and develop and empower our staff. Next slide, please. Okay. Any questions? I know there's been a lot of comment, but I've not been able to read them as I've come through.
Yeah. Thank you, Elaine, and thank you. I think I just wanted to end with obviously this quote, which you can argue whether it was actually Charles Darwin who said it, but I think it gets the sentiment and the message across quite clearly.
Elaine and Sankara, thank you so much. A really inspiring presentation. I was very fortunate to have a preview of it, so I was very excited about what was coming, and you haven't let us down at all. It's wonderful, and it's great to hear, particularly that you've taken what you've done on your own ward and spread that throughout the hospital, and the fact there was sort of 10 to 12 other shared decision-making councils in George Eliot is fantastic. And we're going to talk about sustainability with QI projects. We've talked about sustainable healthcare this morning. We're going to talk about sustainability of our own QI projects in the second half of the collaborative, so really timely. Sankara, you were very kind in sort of monitoring and responding to a lot of the questions in the chat room in real time.
Yeah.
But there are a couple of key bits that I'd like to explore in live, if that would be okay.
Yeah, of course.
The first bit, and I don't know, sorry for bringing people or sort of giving people stage fright, but Marion asked a fantastic question earlier on about patient involvement in establishing the shared decision-making council. Marion, I don't know if you're on the call and whether you wanted to explore that further with Sankara and Elaine. Marion, are you there?
Yes, I'm here. I'm still watching.
Oh, lovely, Marion. Thank you.
Well, I think I was just thinking that I know it might be difficult for you, especially at the moment, from the point of view of a ward in gastrology. I'm sure you have long-term patients. Now, long-term patients who've been on the ward might have some excellent ideas and could be really involved and be willing to be involved in your council if you gave them the.
Oh, you've gone on to mute. Sorry, Marion.
You know, if you gave them the opportunity. I don't know if you heard that, because I am myself a patient, and I have a long-term condition, and I am involved in my local hospital. Not at the moment, obviously, because of COVID. I do meetings for them, and I think if you could involve patients on a more long-term basis, you would get some really good ideas about what it actually feels like from the patient's point of view. And when you've got somebody in the chat actually mentioned this, I think, when you're on a ward round and you've got a whole gamut of doctors and nurses around you in a meeting, it is extremely hard to listen and actually think what you might want to ask at the time. Yeah. But these things might come up at a later date if you had the opportunity. I know it did actually say you've got an opportunity in your amazing plan for the relatives. The patient might not want their relatives being involved quite so much.
Yeah, and that's one of the things that we changed during our PDSA approach, was actually gaining the consent from the patient themselves to actually see if they wanted us to share the information. So that was a really important thing, and making sure the patients had capacity to understand what information we were sharing and if it was okay. But I think that's a really good idea with the patients and expanding their point of view, because they have a different perspective completely.
Yeah, Marion, can I just come in? We already have what we call a patient panel group. In gastroenterology, we've got long-term conditions like inflammatory bowel disease, and we have a patient panel which we set up nearly a decade ago, which is actually coordinated with our IBD nurses, who actually get that input from our patients, and they've been a huge, valuable resource at making some substantial changes in the way the inflammatory bowel disease service is actually delivered within the trust. They've actually done a lot of fundraising and things for us as well, and raised the profile both of the trust and the service to the extent that we now get referrals from across the county and from the neighboring county for inflammatory bowel disease. And that's been a very dynamic process. And what we've done is taken on a lot of what their suggestions are with regard to kind of the patient care on the ward when they come in as inpatients. But I think what you're talking about is more acutely from maybe talking about a patient who's actually on the ward, getting them involved on the council. Is that, am I right in presuming that? Or?
Not necessarily. I think that the idea about your patient panel is amazing. That's the sort of thing I was thinking. Because patients who are fully involved as equal partners do have some involvement, I'm sure, and would do really, as you've said, come up with some wonderful ideas. It's a little more difficult for somebody who is a patient who's just a one-off.
Yes,
because
exactly.
they don't understand the way the ward's working or the way the doctors work and so on. But somebody who's much more long-term has the capacity to understand what's going on. I'm sure a lot do their own research and look up the condition and so on. So,
absolutely.
So,
and I think they do. I mean, that's what I said. They give us very valuable resources because the perspective that they bring is a very fresh pair of eyes, which I think sometimes we don't actually get really. We don't understand what actually their particular issue is with the particular, say, with an IBD patient who has to go to the toilet and the access to the toilet. Simple things like that, which we may take for granted, can be actually a big issue for some of the patients. And I think that's something which we've actually taken on board. And like I said, it's been active for nearly 10 years in the trust.
Thank you very much, Marion. Thank you for your comments. I mean, I think there's two aspects to this. One is the sort of chronic long-term condition and specialty specific side of things. And for many people on the call and on the wards that are working in the collaborative, we have a kind of almost a general medical model. So patients with many different conditions will be managed on the same ward. I certainly, just in the interest of time, I share some of our experience, and we tend to use patient stories. So, we can't use, Elaine, you won't be able to use complaints as a patient story. It sounds like you don't have any anymore, which most of us would be very grateful for. But a patient narrative about their experience on the ward is very helpful in staff engagement and driving change. In the interest of time, I'm going to move us on to another aspect, because Victoria talked about this. John has responded in the chat, and I think Sankara, you acknowledged it already, around the communication tool and offering people, patients and their relatives, an opportunity to document things down ahead of a ward round. Just in the interest of time, I'd like to expand, if I may, just from a personal perspective on that. And I wondered if you have any adjustments or amendments for patients who may be delirious, may have visual impairment or learning difficulties or disabilities. Have you got any sort of nuances around that process that you could share?
Elaine,
yeah. So for people that are more vulnerable, obviously people are vulnerable in hospital, but they're more vulnerable. So patients that lack capacity or are unable to make ask a question for themselves. We actually have started on compassionate grounds inviting a loved one in for, say, an hour a day, providing they've had all the tests correctly done, so we can discuss more face to face those sorts of situations. With regards to Braille, we haven't done anything like that at the moment, but I think that's very interesting. Like, it's seen it from a different perspective. We've took the patients we've got at the moment and acted in their best interests and tried to provide the best we can for them, involving their next of kin or an advocate where possible. But that is something that we could consider.
Certainly the Braille idea, I think, is a great idea, and I think we should probably kind of take that on board here.
That's great, thank you. And John, I don't know if I could bring you in on this, because you've cited a couple of case studies in the chat box. John, are you there? Would you be able to share that with us? Slightly awkward moment when I realised that John has now left the the call. But anyway, for those of you who know aware, so in the Modern Ward Rounds report, there's some examples of one unit, and I think Gordon Caldwell on previous calls has shared his experience of using the communication tool and things. The other question in my mind is the sort of, I guess it's for us all to reflect on, which is the challenge around the desire for a conversation to be had with doctors and patients versus healthcare professionals with patients. And when we work in a multi-professional way, as we do, it still seems that the interaction with the doctor is more important than the interaction with, or held in with more importance than the interaction with other healthcare professionals. That's just an observation. It's just a comment. I just wondered, Elaine and Sankara, what your thoughts on that were.
Normally what I tend to do whenever I'm speaking to patients, relatives, we make sure that obviously Elaine or one of the other staff members from the nursing team is with us, and I make it clear to them that we speak as of one mind, that what we're saying is actually something that both of us agree on and we both see similarly. So I think we make it very clear that we're part of a team and we think alike. And I think that's really important to get that message across every time to the patients or their relatives, because I think a lot of it stems from frustration due to maybe a lack of communication or a lack of understanding, which then tends to them thinking in a hierarchical kind of way, isn't it, about this is more important or that's more important. So we try and make that clear. I certainly make that clear, and I think my colleagues do the same as well, that we are actually on the same page and we're actually saying the same thing, and that we both respect each other's opinions equally. I think that is really, really important to try and get across to our patients at every stage.
That's great. Thank you, Sankara. And I wonder if I'm going to try my luck a second time, because we've got Katherine on the call as well. Katherine is an occupational therapist and is part of our clinical reference groups. Put a comment about this in the chat. Katherine, have you got any views on this from your experience?
Hi, yeah, sorry. No more than I've kind of put there, really. I think that there's a wealth of experience that you can get from lots of areas. Fantastic, this stuff has already been running and up and running for quite some time, which is amazing. And you've probably gone through almost a number of unconscious PDSA cycles with it in determining, you know, a good fit for everyone. I think everyone brings something completely different to the table, you know, and experiences of people are very different based on that. So if you're a frequently returning person, you may have multiple different experiences of, you know, you may also be multiple ward transfers. Somebody who is there longer term and they are potentially getting less and less of that type of population coming through with the speed of flow, also brings something new, but equally somebody who's maybe only been there once or twice. So it's broad and varied. I think it would be good to make sure that it encompasses a broad variety as well. So just thinking about things like learning disabilities, thinking about different you know, ethnicity backgrounds, cultural backgrounds, so that you're getting that broad scope and you're not just speaking to one smaller cohort and actually missing a bigger area. But definitely having, you know, right through, I think some of the biggest observations come from staff who aren't necessarily the AHPs, the nurses or the doctors. So it's really lovely to see that somebody's mentioned about actually having, you know, domestic support staff, pharmacy, volunteers as well. I think they see things differently, might be another area to think about. But yeah, no, I think not much more to add other than that. But I think sometimes we unconsciously PDSA cycle these pieces of work. We just don't call it QI.
Thank you very much, Katherine. And we welcome unconscious PDSA cycles, but for the sake of the collaborative, can people write them down and capture them?
Yes.
Just a plea from the steering group to everyone. In the interest of time, I'm going to wrap the session up. Elaine and Sankara, it really has been a pleasure hearing from you and working with you. I think there's a huge lesson for all of us, and this is really inspiring. If we look after our staff, we look after our patients, and vice versa. And the fact that you've managed this through the adversities of COVID. You've had no complaints, you've got no vacancies. It's just a testament to the work that you're doing and inspiring all of us. So thank you so much for your time today. Thank you for the work that you're doing. For everyone else on the call, we've got a 15-minute break, and then our next keynote presentation is Andrew Molyneux from the British Thoracic Society, who's going to be talking us through differences between QI projects and audit projects. If there are any junior doctors on the call, that's one of my favourite interview questions if you ever meet me in an interview. But there you go. Elaine and Sankara, thank you very much for your time. Thank you everyone for your attendance and for your contributions. We will see you in 15 minutes time. Take care.
Thank you all. Thank you all.